Hello, everyone. Welcome to the Early Childhood Health Consultation November webinar titled Thoughtful Approaches to Exclusion. Should this child remain in care? We are so excited to have you join the conversation today. My name is Maria Morgan, and I am the project manager working with Early Childhood Health Consultation Program. This webinar will be led and facilitated by our very own program director, Dr. Dipesh Navsaria. We are so excited to have you lead the conversation today. So without further ado, I will pass it on to you.
Great. Thank you so much, Maria. I appreciate it. I will just say I'm actually coming to you from out of state right now. I'm in Columbus, Ohio, where I just finished doing a keynote for the Ohio Head Start Association. So see, it's all about early childhood in the end, wherever I go. So thank you for taking time out of your busy days to join us, whether it's live right now or whether you're one of the folks watching this later on a recording. We really do appreciate you being here either synchronously or asynchronously. I'm going to go ahead and share my screen and have that going there and just do a quick little rearrangement of my windows. All right. So again, thank you very much for being here. Really appreciate it. And I really appreciate the opportunity to dig into the question of whether children should remain in care and how we can think about that more than anything. So a few bits of housekeeping. When you join, you will be muted, and I ask that you stay muted so that we don't get any untoward noises or interference there. We do have our eyes on the chat, so if you have questions that come up as you're thinking about things or hearing me, please put them in the chat. We'd love to see them there. And I will actually ask sometimes for some feedback and would appreciate seeing that in the chat as well when I pose certain questions. And then at the end, we'll have a good amount of time for questions and hopefully answers. And as noted, this will all be recorded and posted to our YouTube channel and shared on our website. And there will be a survey at the end. Please help us out, right? We are just getting rolling with these webinars, and we'd like to know what you'd like to hear about and have discussed in different ways. So very briefly, just a few things about the project, and then I'll say a little bit more at the end. This is actually not even an up-to-date slide as of last week because we've been busy hiring more folks to help support us. So there's myself, and you just briefly met Maria as well, who's our ABLE project manager. And then Mabel Jankowski is a student who provides administrative support. We have just hired a nurse consultant again. It is very hard to hire nurses these days, so we're so glad to have her joining us. And then two other folks who are a graduate and undergraduate student providing help. So our team is small but mighty, as I like to say. And this is, of course, a partnership between us. We're based at UW-Madison in the School of Human Ecology, and the Wisconsin Department of Children and Families, who fund us through the Federal Preschool Development Block Grant. But they're more than just funders. They're actually valued partners. We really appreciate their thoughtfulness and thinking creatively about how to address the various things that we pose to them and that they pose to us as well. And what is the Early Childhood Health Consultation Program? Just in brief, we're there for you, early childhood education providers. We want to help you address health-related concerns and offer guidance on the best health and safety practices. We recognize that you don't necessarily have great ways to receive this information that apply specifically to your setting. Even K through 12 schools have a school nurse. They don't have enough of them. They're not always available enough. So not implying that. But of course, that looks great from the ECE world where you generally don't have as much anywhere near that level of support. So we're pleased that DCF had the vision to say yes when I raised this to them a few years ago, and to say let's work on building this out and make sure that you folks have the support that you need. What do we aim to do? We are slowly be statewide, and really allow you to have that health expertise through a consultation model to do all the things that we just talked about. I'd like to do a brief land acknowledgement, even though I'm not currently on the lands, the ancestral lands of the Ho-Chunk Nation. That is, of course, where my office and the School of Human Ecology is based. And we're pleased to have relationships with some of the tribal nations throughout Wisconsin and ultimately serve all of their ECE programs as well. I have a long-standing relationship with one in the state that I've deeply treasured over many years. All right, so let's start off with just doing some level setting here. I'd love to see responses in the chat here in 5 words or so. I'll give you 4, 6, etc. What does it mean for a child to be sick, right? When you say this child is sick or ill, and you know, you're thinking about calling a parent or sending them home, or at least telling the parent at the end of the day. How would you define that generally? I'll give people a few moments to think about that and put some thoughts in the chat. I'll let you interpret that question however you like. And I've learned from virtual teaching and hyper teaching that since Zoom doesn't give us the little pause here, oops, and oh, the chat is disabled, I'm seeing. Thank you very much for folks to tell us that in the Q&A. Maria, are you able to re-enable the chat there?
I am trying to do so, but for the interim, why don't we go ahead and utilize the Q&A feature for the time being on this first question. Thanks everyone for your flexibility.
Yeah, thank you. As you can all imagine, there's about 1 billion options with Zoom webinars, so we're just getting this all figured out here. Yep. So I am seeing some of those responses appearing here. Yeah. Child is sick when they can't participate in regular routines, or if they're contagious and putting others at risk. Yep. A fever can be part of that. Quiet, slow, not themselves. Yeah. So just looking at their behavior. Not able to participate, seeing a lot of that. Uncontrollable cough. A lot of folks are going for participation. Yeah, that's a big one, isn't it? We'll come back to that. Unable to keep up with activities, not acting themselves. Yeah, that's a key one. I've used that a lot myself in clinic sometimes, is to ask a family, like, is your child usually this subdued, or is this unusual for them? And I did get the, oh yeah, they tend to be quiet, or oh no, they're usually running around like a maniac. This is unusual. And that can be very helpful to me. Yep, less than average, not acting normal, throwing up, fever, diarrhea. Okay, wonderful. Depends on the teacher's opinion. Yep, and part of why we're doing this is to try to help offer more consistency there. Fussy, yep. All right, I'm just not going to read these all out. There's so many wonderful things that you folks are putting in here. Defining fever, again, routines. Wonderful. Thank you so much. There's really so much here that really gets at a whole series of different ways to think about, you know, what's going on. Something negative is going on in their life. That's another one there. Yeah, wonderful. Thank you. I appreciate that. That really highlights the different ways we can think about this, and all of these are correct in their own ways, right? About what does it mean to be sick or ill in different ways. So now let's, using whatever definition it is of a child being sick or ill, right? That something's doesn't seem quite right. I wanted to do like a 3-part little thought experiment here, okay? So let's put ourselves first inside the head, right? The frame of mind of parents and families, okay? You get a call, you know, or a text or whatever it may be, from your child's early childhood center, saying, hey, you know, your child, you know, appears to be ill or sick, we think you should come and pick them up as soon as you're able to, because we think that they shouldn't be here for the rest of the day because of this illness. What's going through that parent's head potentially? What sorts of things might they be thinking about? Again, I'll invite you to put that in the Q&A there. Oh, and I'm seeing that the chat is now functional. Thank you very much, Maria. So we can switch over to the chat. Yeah, having to miss work. That's a hard one, isn't it? And sometimes workplaces can sometimes be very forgiving and sometimes not so much. Yeah. Finding alternative care. Yeah. Look, I'll tell you, me personally, we when my kids were young, my in-laws were nearby, but my goodness, they also my in-laws have plenty going on, running their dairy goat farm and so on. So it wasn't that my mother-in-law would just drop everything and come over, far from it. Yeah, what am I going to do tomorrow? Yeah, loss of income. And that's not the same for everyone, right? If I have to take a day off of work, my kids are now in college, but if I had to take a day off of work, it's usually not a huge deal. But my goodness, day laborers especially, right? They're paid by the hour. Yeah. Is my kid sick? Do I have time? He seemed fine this morning. What's going on? Yeah, could it be allergies? And allergies are common. Yep. Is my kid sick enough that I need to go get them now is another theme that's coming through here. Yeah. But a lot of this is like, oh gosh, what am I going to do? How do I have to do this? Yeah, I still have to pay for the day, but my child doesn't have care. What else do I need? Do I need to go to the doctor? Right. Yeah. Okay, great. Thank you. I appreciate these thoughts. So now let's think about, let's go into the shoes of who of most of you, right? That if you're an early childhood educator, and you're making this call, you're looking at this kid and you're thinking, okay, I got to call these folks. What is going through your head? This should be easier because this is something that you live all the time. Not again. Yeah, the parents will be angry with me, right? That's so hard to make that call, isn't it? Right. Yeah, okay. Did the parents know that this kid was sick and medicate them and give them some Tylenol and drop them off? If you're a home provider, yeah, is my family going to get ill, or are the other kids? How can I show empathy and concern, in this? Yep. Uncertainty, because we're not healthcare providers. Thank you for naming this whole reason this project exists. Who else do I need to inform, right? COVID has really made this one challenging, hasn't it? Right, like having to suddenly do all this reporting, but we've had to do this for other things as well, haven't we? Yeah. Contagious. Am I going to get sick? Feel bad. How long are they out? Especially if you're only paid by the day. Yeah, all those sorts of things there. Am I making the right decision, right? Should they go home or not? Yeah, that's a tough one, right? Yeah, I'm not a doctor, staff. Are they contagious? Yep. Yep. What do our policies say? Yep. Yeah. Okay, wonderful. Yeah. Use teething as an excuse. Let's hold on. I don't want to get sidetracked here. If we have sufficient time later, which I hope we will, I have a few thoughts on teething that I'm happy to share, but I won't go there right now. Yeah, can't isolate this child. Yeah, all right. Thank you. Wonderful. All right, now I'm going to give you what might be the hardest mental stretch that you need to make today, which is, what if you're a healthcare practitioner, right? Families coming in, or they're calling, right? Or maybe they're coming in, either scenario. and saying, my child, I had to go pick them up from their center. What should I do? And what might a healthcare practitioner be thinking, either if they're seeing them already, or if there's a phone call coming in and the nurse is trying to field this call and offer advice? Put yourself in that setting. What might you imagine that they might say? It's going around. Yep. Yeah, issues that don't need medical care but require a visit and a note to go back in. Yeah, they cut it from childcare. Not fair. I understand that. Yeah. Is it self-limiting, or is it something that requires treatment? Yeah, do they really need to be seen? Just go to urgent care. As someone who spends much of his clinical time in urgent care now, yep, I feel seen. Thank you. Uh-huh. Yep. Tough decision. Hoping you don't have to close down classrooms. Do I have all the facts? What are the childcare rules? Yep. Once they're medicated, they aren't contagious. Yeah, that's certainly not a blanket rule, but yeah. You know, yeah, try a nurse line. Yep. Uh-huh. Yeah, were there other kids sick? They don't need to be seen. They don't need to be seen. Right. Yeah. And I will add that COVID throws a monkey wrench into all sorts of things because of the public health implications of it. So a lot of the talks we do, we're ending up kind of, tiptoeing a bit around the COVID question, because that's kind of a special case, but a significant one. Yeah. Is it more serious? Yeah. Yeah. Great. Thank you. I'll offer more perspective on this as we go ahead here, but thank you for doing that mental stretch there. I appreciate that. So here's the question that often comes when I'm seeing children in clinic that have been sent home from their early childhood setting. When can my child return to childcare? Right? And there's the implication of this, right, from a parent perspective, is that there must be some set of rules that everyone else knows, right? That the early childhood education world knows, that that we in healthcare know, and that there's 100% agreement on this, and that there's some sort of standard. And you know as well as I that that's not actually the case. There are differences of opinion, certainly among healthcare practitioners about things. And sometimes we don't have great evidence for a question like that. If COVID has taught us nothing else, right, it's that there's a lot of variability in where what's the line there about when children can, or when children are still contagious or not, right? So some are contagious for a short period of time, some are contagious longer, et cetera, et cetera. And it does go all over the place, and it's deeply challenging. And this is frustrating to parents, right? Because what they're sometimes hearing is, well, this is the center's rule, okay. And on the other hand, they're having a healthcare practitioner saying, well, it's not so clear cut, and they feel often kind of stuck, like, okay, but this is posing a challenge, in many ways. So it's this expectation that there must be specific criteria laid out, that there's a purely medical decision, and that's out there. So I think if we think about this for a moment, right, what that question does, and what often the request is like, I'm here with my child, I need a note so that they can go back. Or I need to know if you can provide a note that they can go back. What that's doing is it's making us in healthcare, it's making us the gatekeepers, right? That we're the ones who have to deem, is this child actually contagious or are they not? Can they go back? Can they not? And here's the thing, I have a certain set of knowledge and expertise and experience that's over time, but at the same time, there's a lot of pieces that I don't actually know, right? And I'm seeing some great questions popping up in the chat, which I hope will answer in the course of my comments today. So I'm not intentionally ignoring them, because I do think we'll get there, but they are awesome questions, right? So I can tell you about that child's individual health. I can tell you about the likelihood that they'll become more or less ill, or whether it poses a threat to them, and so on. But there's a lot of things that I don't know. So here's the thing. I view this as I nor any other healthcare provider should be a sole gatekeeper of that. That this should actually be about shared decision making. Okay. So I can do the, is this a contagious illness that's harmful to others? Or they're clearly too sick to leave home, or that this child is at risk, right? Like they need some sort of more intervention, hospitalization or something, right? Which that's rarer, but still, right? But that's something that I have the experience and the expertise and whatever to generally be able to make that judgment. And I wouldn't expect a parent or a teacher to be making that call about those specific questions. The parent, however, knows their child really well. They right, they spend the most time with them, throughout their lives. They've been able to see them, from the moment they were born, or at least very young, and all. And they're the ones who I turn to often and ask about, like, what is your child's behavior like, right? As I mentioned earlier. And also that parent knows what their social and work situation are like. You know, can I easily ask, a relative, a grandparent or someone to come over and watch them? Can they afford to stay home? Does their employer allow remote work? I wouldn't know that. I can ask it, right? But I wouldn't know that, and I wouldn't know how to judge all those sorts of things. So the parent has those bits of information that are really, really important. And then finally, there's you folks, because, and this is coming out so well in the chat comments here, and I so appreciate this, you can assess, right, does this child need a lot more care than we can reasonably take on, right? You got to think about your staffing ratios. Do we have a spare person who can help out if a child just, needs more comforting and holding and things of that nature, right? That you can make that assessment, because I certainly don't know. And let's face it, the parents don't necessarily know. How many personnel do you have? Are you short-staffed today? What are you set up for or not set up for? What are the care needs that need to happen, right? So you have that information as well. So I think if you put all these things together, right, that's really why this is a shared decision ultimately at the end of the day. And when we do shared decision making, right, it keeps us from ideally leaning on rules or criteria that are sometimes very detailed, but don't actually have evidence, behind them, right? That's saying, well, it must be this much time before blank, right? There's evidence for some, and I'm not saying there aren't, but there's often kind of these rules that are made that the healthcare practitioners are looking and going, I don't know where that came from. Okay, that way it keeps them frustrating the parents. And it's legit to say, hey, your child is needing a lot more care than we're able to provide. That's frustrating, right? I think to parents, because they want their kid in care for whatever reason. And I think that's important. But really doing this shared responsibility and saying who has all of these elements, and how can we think about this together, and keep our focus on the best interests of the child, right? But there's all these sorts of things that play into it. So when a child is in care and they're ill, right? These are often the questions, right? When should they be sent home? When should we be asking them to actually see a clinician of some sort in healthcare? And when can they return to care? So this is where I want to spend a few moments talking about the Caring for Our Children guidelines. These are a collection of national standards that represent just really the best evidence and expertise and experience for early care and education settings. This is a collaboration. The American Academy of Pediatrics is involved, the American Public Health Association, and then the folks who kind of oversee it are the National Resource Center for Health and Safety in Child Care and Early Education. This has been through multiple editions, and actually it's now being continuously revised. They're no longer doing like edition to edition because they realize that there's a lot of things that shouldn't wait years until the next edition and all. So if you go to the website, and if you just type "caring for our children" into Google, you'll get to it pretty easily. Lists the most recent changes, and you'll see there's even like 6 or 7 batches of small edits and revisions that have been done this year, this calendar year alone. And what I like about this is because the people who put this together, it's a pretty large oversight group and all, are thinking really thoughtfully about all these things, right? They're not trying to be pro-doctor or pro-parent or pro-early ed teacher, right? They're keeping the focus on kids, and they're keeping the focus on kids in early care and education settings, right? They're not trying to just apply generic advice that we might give to parents and say, well, just apply that to care and education settings because, you know, as for all the obvious reasons, you guys are different. You have, you know, many more kids together, you have staffing, you have, you know, ratios of kids to providers, et cetera, et cetera. And this is often where I turn to, you know, when there's a question is there something on this? It's meticulously documented, including the references for where they're getting their information from. And it's pretty clear in how it's laid out. So I often turn to this because it is the single best piece of work out there. And it's strangely not very well known amongst many early care and education providers, which is another reason that this project exists, is to try to help people know this exists and to help apply it in useful ways. They point out very clearly, thank you for putting that link there, I appreciate it. Most illnesses do not require exclusion. Okay, this is a true statement. That's, of course, that statement on its own does not provide enough specificity, right? But they do say that. And here is the opening. I'm not gonna, as one of my colleagues in another program says, I'm not gonna do a dramatic read of the entire standard, but the famed standard 3611, we talk about this all the time in our project. This is the opening words, right? Children in early care and education programs can often become ill. Most illnesses are mild and do not require dismissal or temporary exclusion from programs. But some infectious diseases do require temporary exclusion to control the spread of illness in the program, right? That's their opening frame, which I think is very important to say most illnesses really are fine. And they talk through various elements of procedure. Again, I'm giving you just snippets. This is not everything that's in there. But here's, you know, some things that I think touch on some of the excellent points that you made, right? Deciding what constitutes an illness that one can say. You know, let's face it, we also know that young children, meaning the children that you all serve, get a lot of illnesses. A lot of illnesses, right? This is sort of their job. Their immune system has to see all these viruses and do that because this is what happens unless you're going to live in the woods away from civilization, right? So deciding what constitutes something that you know, is something that they can stay for or not is important. And if you decide they don't need exclusion, fine. Making sure the parents know that's important is good. Or if there's, so tell them when there's new signs of illness. Obviously, there's an emergent or an urgent issue. Don't wait. Tell them immediately if there is exclusion, right? This is obvious. I know you know this. But I thought it was key here that they said, only ask for a healthcare provider's note if you need that advice about, is this a health risk to others? Which should be a reasonably rare situation, but it's a valid question, but it could be handled by a phone call as well. Or if you need more information about special care that the child might need, right? Are they receiving some medication that you're not sure how to administer and the instructions you got were not clear, right? That's a very valid reason to say, hey, we're not sure what we're doing with this. We need some guidance or advice here. To please tell us what to do with this in different ways. Oh, okay, right. But I still think this child doesn't look well enough to be here. You guys already predicted this slide. You said a lot of your comments said, I'm just looking at them and, you know, something still doesn't look right, right? Yeah, of course, right? There's that gestalt. I actually talked to our trainees about this in healthcare, right? That there's the moment when you walk into a room and you just like in the first 6 seconds, you look at a child and you say, they don't look so well, right? This is uh-oh, right? This is unusual. And I don't know what it is yet because I haven't gotten any history. I haven't done an exam, but I'm just looking at them and this doesn't look so good. Right? Yeah, that sort of overall gestalt does matter, right? So here's the key reasons, right? To send a child home to a non-emergency illness due to that. You already anticipated this in your comments. They can't comfortably participate in activities. Yes, you're saying, wow, they seem really puny is the word that's sometimes used, right? They're fussy. They just seem really tired, right? They're just not able to participate. That's an okay reason, right? It doesn't have to be about a fever or something else, right? Or this child needs more care. We talked about this, than you can provide without compromising the health and safety of other children, and then risk of spreading harmful disease. So yeah, what's considered harmful disease? That's actually laid out in caring for our children in more detail. Um, it's a list, right? And a lot of it does overlap significantly with the DHS communicable disease chart as well. So for example, right, take one that we all know about, right? COVID, right? COVID has significant issues there around that, around public health and so on, right? So if these are things that are consistent with COVID, you might, consider doing that. Yeah, it's a good question you're asking there, Melissa, about medical determinations. We're not saying medical. So if you look at caring for our children, it doesn't say there are sections about particular diseases, but there are also sections about symptoms, right? So like what's the kind of rash that you do need to worry about versus the kind of rash that you don't. Okay, because we wouldn't expect you to diagnose the rash, but we would say, well, here, use this to help guide you. And if you're not sure, it's perfectly okay to say, fine, let me ask for that to be looked at, or to reach out for a consultation and ask. We might not be able to get back to you in as quickly as you may like, right, at this point. But you can ask for that evaluation to be made. But the point is, what I want to highlight on this slide is actually the middle box and the box on the left, which is, again, your gestalt about how this child is actually doing or what you're able to provide as a center. Those on their own are actually reasonable things to take into consideration and to explain, as opposed to giving a criterion that may or may not be something that is agreed upon universally in different ways. And when does the child need to see a healthcare professional? The answer is, for the most part, not usually, right? Most do not require a visit to primary care, urgent care, or whatever. And if the child has seemed to get better and no longer meets the reasons that to be excluded, you don't need a letter or a note necessarily to do so. My son, who as I mentioned, is now in college. To this day, he still has what we call the micro sick, where he's ill for like 4 hours and then better. It's very odd. Like he just, he's sick, he's not feeling well, whatever, and then he's better like really rapidly, as opposed to my daughter who doesn't do that. You know, sometimes kids can go through these things very quickly, and sometimes not so much. The point being that what we're trying to do is to also say visits have a cost to them, and I don't just mean a financial cost. There can be a financial cost. That are co-pays, co-insurance, deductibles, et cetera, that can add up sometimes very quickly. But there's also, right, having to haul your child in, sometimes the siblings as well. If you're going into urgent care at night, right, it's a long wait. Great, you're there for 2 hours. I get to walk into a room of kids who are cranky because they're tired. At least one of them's ill. They're missing dinner, so they're all hungry. Uh, you know, it's a really big burden sometimes, especially if it's just, well, we need a note, right? And so on. So I think asking yourself, what purpose does the note serve, and what's the reason that I need that for? If there's something that you say, yep, I need some information here, or I'm concerned about this, pass on that concern. Please share that concern, and that makes a key difference um, there in terms of helping answer your questions. I'm thrilled, actually, if it's a written question or something from a center, that great. I can actually write that note and specifically address that. I rarely see that, the question being that specific. We love to have that direct communication, or at least through the parent in that case, to make sure we're answering what your needs are in healthcare in general. Now, when should they? Of course, there's many times, right? If the special needs that the kid might have, or if somebody's like, hey, is this actually a significant risk to others? It's not covered by any of the criteria or the guidance that's out there. And then, of course, I mean, active TB, yes, active TB, which is thankfully rare, is a special circumstance. Little typo there, it's rash with a fever or behavior change, right? Because then we do worry about the possibility of meningitis or something like that. Or mouth sores with uncontrollable drilling, are also. And then, of course, that changes the situation. I would argue if any of those things are happening, parents would be concerned, and we certainly want to see them. I think also recalling that not all care needs to be a direct face-to-face visit. COVID's taught us anything, it's that there are other options, right? That a phone call or a message through a portal like MyChart or whatever your local systems may call it might be a good place to start, because sometimes we can talk through things on the phone and say, I'm not sure this child really needs to be seen here, and we can answer the questions that are necessary, and do so. Or direct people to a faster or better source of care, depending on what's going on. I also completely get it that we, much like in early childhood, we're facing all sorts of upheaval in healthcare, and even getting an appointment or even getting through on the phone or something on a timely fashion is a deep challenge. I even say this as a parent myself, trying to sometimes get some questions answered about my own family, even though I work in the same health system. It's a challenge. And of course, if the parent's concerned, they should always know they can seek advice or care, right? I'm happy. Much of my work, honestly, is reassurance, right? Because of so much of what we see are viral, self-limited respiratory illnesses, right? That a lot of it is reassurance, and that is absolutely okay. But I always say starting off with a call or a portal message just for someone to work things through, maybe a good start. Very briefly, I thought I might share with you a very current example of how I might think through this. So yay, RSV. I'm sure many of you are dealing with this. We're dealing with it in healthcare. It's really kind of nuts. I think this is the worst RSV season we've probably ever seen, and all. So here's what the guidance in caring for our children says, right? It points out what it is, right? It's a common cause of respiratory tract infections, but it can happen in all ages. If they have RSV infection, they can return to childcare when symptoms are resolved, temperatures return to normal, they can participate in childcare activities, and the child's care does not result in more care than the staff can provide, right? That's the same language there. Christine, great question. It completely matches that book, Managing Infectious Diseases in Childcare and Schools, because that's published by the AAP, and they work very hard to make sure it's consistent. Yes, I actually know one of the editors of that book, and yeah, there's very clear communication, because it's not fair to you if you're getting two sets of guidance from two different sources. So thank you. So that points out the definition, it points out the criteria for return, etc., and lays that all out there. Now it specifically talks about childcare settings in RSV. Most children and staff will be exposed before specific symptoms occur, right? It's very easy. And most are self-limited and diagnosed. So here's the thing. RSV is causing a lot of panic and has for some time, like every year in RSV season, and we're hearing more of it now since it's in the news. I guarantee that every single person on this webinar right now and every single person watching it, on recording, has had RSV multiple times, probably in the last few years, if not even this year. In most grown-ups and older kids, it's a cold, and that's all it is. And so the real issue is primarily with the younger kids, the infants and toddlers. And even then, the vast majority of kids with RSV do not need to go to the hospital. They do not need any particular treatment. They are actually doing just fine. The reason we worry so much about RSV is because, well, there are some kids who do end up in the hospital, right, and do even end up in intensive care. It is different in that way, but it's certainly not the majority of kids there. So this is why, and they say, again, this is through respiratory tract secretions. Now, there are some kids for whom RSV is a bigger deal, chronic heart and lung problems, immunocompromised children, et cetera, et cetera. And if you have a child that has all that, has those particular conditions, right, those parents and guardians should probably be alerted about RSV. Would I necessarily tell everyone that, oh my goodness, when somebody had RSV? Not necessarily, because again, for many kids, it's going to be a cold, right? And it's not going to change much. And if you're going to report all cases of RSV to everyone, to the entire population, then you're also going to have to consider doing that from elsewhere. Donna, you point out that in 38 years, you've not had a child with it. Actually, I'm going to tell you, you almost definitely have had multiple times. It's just that they were mild enough that they were diagnosed as colds and not RSV, because again, mild RSV looks simply like a cold. And we generally haven't been testing for it for many years. We now have testing. I am also going to let you know that if testing is not going to change what we do for them medically, we do not recommend testing. It actually adds $300 to the cost of the visit, and it doesn't change what we tell them. So I think it's important. Asthma, if it's well controlled, is generally not necessarily considered to be a higher risk for RSV. Yeah, why the hype? I think it's because there's so many kids right now with RSV that are being hospitalized. This may be secondary to a lot of young kids right now having not been in early childhood settings or where everyone was masking. So look, March 2020, we had actually a pretty bad flu season going on. The entire flu thing collapsed in 2 weeks when we all masked for other reasons, for COVID, right? So because of masking, et cetera, we haven't seen a whole lot of RSV transmission, et cetera, et cetera. So now we're getting a whole bunch of kids who've seen zero RSV, and so on. So yeah, because it's so contagious, what about those days a child is contagious? Well, guess what? They were probably well contagious before they had symptoms. Everyone was exposed. If they don't have any of those other things going on that would lead them to need to be excluded, that is not, excluding them simply for that time period actually doesn't make sense, because everyone's already been exposed. And if you're going to say that for RSV, you need to be willing to say that for all sorts of viral respiratory illnesses. And that's actually pretty much means you can't have early childhood settings, right? Because again, this is so common in different ways. So again, if we come back to this slide, which I mentioned before, right? Can't participate comfortably, care needs are too high, risk of spreading harmful disease, right? If you're looking at a child and you're saying they're not comfortable, they need more care, those are the key things. And again, you saw the exclusion criteria there for RSV. So again, we can do a whole thing on RSV, and we probably should at some point. But the point was to show, like, this is where turning to caring for our children and being able to look at that, I think, makes a key difference there. So with that, we're at a quarter to the hour, and I want to make sure I get at questions that we haven't addressed around thinking about shared decision making, about how we approach all of this. Again, there's no way I could cover all the specifics, but Caring for Our Children, or the Managing Infectious Diseases book that was mentioned in the chat, both can have much of the details, and we're going to continue working on all of those things that are there. How can we create an exclusion setting to prevent families from needing to miss work? So basically, a center for mildly ill kids, I think, is what you're asking for there. Yeah, that's we got asked a question about that recently, and I need to spend some time digging into those criteria with our colleagues at DCF, and trying to understand, right, like what are the pros and cons of that? What are the economics of that as well? It is a hard one, although I'm going to also say that one of the weird benefits of the pandemic may be to actually think about that with so much work from home and remote work being possible now, not for everyone, but for many, right? Does that change that need to a certain extent? Now that's going to be employer by employer. We can't mandate that, right? But for people to be able to now say, well, heck, I can work from home and be working on those documents and keeping an eye on my own child when they're ill and still be working, may actually be very liberating in some way. Are you saying that fever, vomit, and diarrhea are not criteria for exclusion? They can be. Okay, they can be. And again, exactly what we're saying, and I see a question about pink eye as well. It all depends specifically on what's there. And coughing, right, coughing is a symptom for so many things. I recently did a session with our physician assistant students on a case of a child with cough, and we spent about half an hour just walking through all the possible things that a cough could represent, for all of those things, because yeah, it does actually do all of that in there. So I would look at Caring for Our Children, because it talks about the subtleties that matter around all these questions, right? About what constitutes diarrhea, how much, vomit, fever, etc. Because that's where I would turn to and say, what have they seen in terms of the criteria? What have they seen in terms of the evidence? What's likely to think about spreading and things like that? I want to answer, I see two questions about when is it COVID? Yep, because we're still dealing with this. I'm actually sometimes a little surprised in urgent care settings, personally, when a child has cold symptoms of any type and they are not, and the family has not actually done home testing at all, because rapid tests are readily available to most. They're covered by insurance, et cetera, et cetera. I think it's perfectly reasonable to ask a family to do a rapid test at home. I don't see any issue with that. I would not make them go and get a PCR test unless it's a really unusual situation, because then you actually have to go in somewhere, get that done, et cetera. Home tests the rapid tests are actually quite reliable. And if they tell me that they tested and tell me if it's positive or negative, great. I'm good with that. I don't need to repeat it again unless it's an unusual situation of some sort. I think asking people to test is really important. I'm going to say it's not as difficult as I think it might appear. Now that we have good data that doing a swab just in the very front of the nose, the anterior swab, as opposed to that, back of the nose brain tickler one, which they still make me do in clinic. I don't enjoy doing it on kids, but whatever, is reliable. It's actually not that difficult to be able to do so. So yeah, I would definitely consider testing. I do see a comment about health policies, and I will just preview that our project is working with our friends at Department of Children and Families to do a model health policy, like a template that will allow you to be able to fill in things and reduce the work that you need in order to revise or update your health policy, and just offer some consistency and guidance about all of these things there. Yeah, reliability of tests for kids under 2, great question. There's actually not a reliability question. It's just that they were never tested on kids under 2. COVID virus is COVID virus. It's going to pick them up. Now, would I recommend that you as a center use rapid tests for screening? No. On kids under 2? No, because they're not FDA approved for that. Have I told families they can still do them? Yes, I have, at home. There's no issue there. It's just simply that it hasn't been tried out there, and so on. There is a question here about, oh, and I'll just say one more thing, this because I see a question about rapid antigen tests. Yeah, I would still do 2 tests 48 hours apart if the symptoms persist. We are seeing early symptoms that you're not positive yet, but then you do turn positive later. The good thing to know about rapid tests is that rapid tests are a reasonable proxy for whether you're infectious. So if someone was around but negative, was around other people but negative, and they don't turn positive till the next day, right? There's a pretty good chance that they weren't actually shedding much virus, if at all, early on, right? So that's actually something that may reassure people, somewhat. There is some question about, in some of the questions in the chat here, about the difference between reportable diseases and like communicable diseases that are an actual cause for concern. Certainly, you should follow the guidance of your county health department in things that you do need to report, and so on. Some of those can sometimes be out of date in terms of what's needed or required, that's out there. And actually, if you're seeing something like that, that you say, "Gosh, do I need to do this?" Hey, reach out to us. We're also happy to kind of work with health departments and others if there's something that's truly burdensome or onerous, to make sure to kind of address that. Yes, I see more questions about fever, fever reducers like Tylenol or ibuprofen and so on. I'm going to also say that fever goes up and down even if you're not giving medication, right? So I think that when we do things like, say that someone should be, fever-free or whatever, it creates an incentive to make the fever go away, right? In some way, shape, or form. It is not unusual that a child does have something spike during the day, and then at home they end up being fine, even without medication. And then they might get sick again later. I mean, I think as adults, we've all experienced this too, right? That our symptoms kind of wax and wane in different ways. And I think that, I wouldn't go simply based on fevers again. It's what's the symptoms that are present, and recognizing when they are or are not having something that's of concern in the other ways that we talked about here. I see a question about hand, foot, and mouth. I don't know if I would say it wasn't contagious, but I am going to say that hand, foot, and mouth is a pretty innocuous, self-limited viral illness, meaning that it's not particularly dangerous. It doesn't, we rarely see a child with mouth lesions that are severe enough that they, aren't able to eat or drink much, but that's pretty unusual. Most are about as severe or significant as any cold virus. In fact, maybe even less so. And it's no more than that. And so, I think it's, again, asking, okay, why are we excluding them? And if you look at caring for our children, they specifically address things like that as well. Wow, there are so many things here. Yep, if a COVID test is positive, you should be considered to be shedding virus until the test comes back negative. This is not something that the CDC has been fully officially endorsing. They're doing it a lot in a lot of European countries. So the COVID test, that's the PCR test, Marie, that can be positive for 3 months afterward. Rapid test, not so much. You know, cough only, test negative with a rapid test. Would we recommend they stay home? That's a hard one, right? It's really, really hard to know what to say there, because 48 hours is a whole 2 days. It can be pretty significant impact. And most of the illness that I'm seeing, in at least that's coming in urgent care, is actually not COVID. All the tests are often coming back negative and continue to stay negative. It's actually adenovirus, rhinovirus, and so on. DCF licensing. Yep, we are totally committed to working with licensing and regulation so that it is consistent. Totally hear you. We've already met with them once to kind of explain our project, et cetera, and we have planned meetings to make sure that everything is consistent, because it is no fair to you folks if we're not being consistent in different ways there, and so on. All right, we are at 4 minutes to the hour, and I want to make sure that we are respectful of everyone's time here. To answer the other questions, yes, we can share the slides, and we can also, and all this will be recorded and online. A few last things to say in closing here to just share with everyone. Right, we're here for you. So anyone in the state, even out of the state, we don't check where you're logged in from, can access our resource library or our webinar trainings, of which this is the first, right? That you can, that they'll be there recorded. You can access at any time, listen to again, share with others, whatever the case may be. And then there's our health consultation, in which you can specifically reach out with your questions through texting, calling, emailing, or a form on our website. You'll be contacted by a health consultant. We'll pull together resources to be able to answer your question as well as possible. Send, reply to you, and then also try to do a follow-up and make sure that we that you found the information useful. Do you have other questions, et cetera, et cetera. This is limited at this time only to Adams County, Rock County, and the Le Corderet tribe. We are, now that we've been just recently fully staffed up, we'll be working to expand to other counties, because we want to make sure, but those other resources are available to everyone. Okay, it's just the consultation that we're trying to make sure, because if this barrage of great questions that you're asking is any indication, right, we will get bombarded, which is great. We want to try to serve the whole state as soon as possible, but we want to make sure we're prepared for all that. And do remember, this is all virtual. We do not do on-site visits or anything like that. Who knows, maybe someday in a future state, but not so much. These are tailored for what you need, and they're absolutely free. This is your federal and state tax dollars at work. We don't even have a way to charge you for anything, so don't worry about any of that. Here's our phone number, which you can call or text, our email, and of course our website, which has a lot of the resources, and Maria's putting that in the chat as well. So that's all on there, and there'll be many more things appearing on the website in different ways. I imagine that if there's any policy changes coming through on DCF's side, it will be communicated through the usual channels, definitely. And we're also on Twitter and Facebook if you want to follow on either of those two platforms as well. We post a few things there as well. Thanks to the ECE providers, including those who are on our advisory board, who help us try to get this all right. Our colleagues from other child care health consultation programs across the country, there's only about 12 other states doing this. They were really envious here in Ohio when I mentioned this. Of course, our friends at DCF and School of Human Ecology, and there's been multiple people who are no longer with the project and have moved on, students and others. and all. And thank you so much. I'm going to have a punt on the teething question just to stay on time, but I will make sure we get back to it at some later point. So thank you so much. And thank you so much for all that you folks do. I mean, I spend so much time talking to early childhood educators, and it's a delight to be able to share things with them and to be able and to tell them, look, the whole reason this project exists is because I recognized you folks don't have the support you need around health and well-being. So this is what we're trying to work on. Thank you for the kindness in the chat. I really appreciate it. And thank you to all that you do.
Great, thank you again. I am going to be putting in our post-webinar survey into the chat. This is accessible through a hyperlink that will launch a quick 1 to 3 minute survey. Not only do we appreciate the time you guys take to offer us your feedback, but this is also the opportunity, if you would like continuing education credit with the registry, for you to enter your name and registry ID number. So again, that can be located in the chat through our Qualtrics survey. As we wrap up, feel free to reach out. We had our contact information also located in the chat. And thank you all for your time.